Um, all right. So for those of you who do not know me, my name is Allison Cihla. I am a pulmonologist. I work at Preston Memorial Hospital, and I've also been a part of this group for the last 8 years, I believe, as the pulmonary consultant. So today we're going to talk about chest radiology. Um, there are a lot of slides, and I again apologize for the late start, but I will try to get through as many of these as possible. And if we don't, I can always pick this up on a second lecture if you all desire. So our goal with radiologic studies is to recognize something that is abnormal. So in order to do that, you need to know what normal is, and then you want to be able to characterize what that abnormality is and localize that abnormality. The first thing you want to look at when you're looking at an X-ray, is it acceptable? Can you see the different anatomy, the lobes, the fissures, airways, vasculature? Are there specific signs that you're looking for? And we'll talk about some of these, like the silhouette sign and the air bronchograms. You also want to be able to identify anything that is external or not part of the human body, such as line tubes and drains. And then ultimately, you're looking for any type of disease or abnormal findings. Um, Our goals for today are here. In the interest of time, I will not read through all of those, but this is what we will talk about today. So first, we are looking at chest x-rays before we move on to CT scans. And this is a PA view, posterior, anterior. And so that's the way that the beam of light shines through. And you can see the x-ray that is produced on the right-hand side. This is a lateral view, and again, this has to do with how the beam is shown through the body, and the view that you get. So on a normal PA chest X-ray, these are the landmarks that we're looking for when we're looking for that normal anatomy. You can see the spinal processes, you can see the trachea, you can see anterior and posterior ribs. Um, you can see the diaphragm, the liver, the stomach, or gastric air bubble, some soft tissue, and the aortic knob, as well as the clavicle and the scapula and some of the other bones. In order to get a good chest X-ray, the patient should take a full inspiration. This helps to determine if there's any sort of intrapulmonary abnormalities. And in order to determine whether the patient got a good inspiration, you should see the diaphragm at about the 8th to the 10th posterior rib, or the 5th to 6th anterior rib on good inspiration. And so this chest X-ray here is considered a good inspiration. If you count the posterior ribs, we are at 1, 2, 3, 4, 5, 6, 7, 8, about ninth posterior rib. This is what happens when a patient's chest X-ray is taken on expiration. You can see on the left-hand side, there's some fuzziness where the red arrows are pointing. That is the right heart border, and you really lose that clear right heart border. And the problem with that is that that's also the location of the right middle lobe. And so on this first X-ray on the left, you may be concerned that there might be a middle lobe pneumonia there. But if the patient takes a good inspiration, you can see on the left-hand side that heart border is nice and sharp. You can see where the heart meets the diaphragm, where the red arrow is on the X-ray on the right. And so no evidence or worry about pneumonia in that X-ray. The next thing you want to look at is penetration. You want to make sure that you're not getting over penetration or under penetration. You want to be able to see the thoracic spine disc spaces, barely through the heart. Usually you cannot see the bony details of the spine. On the lateral view, the spine should darken as you move towards the head. And so you can see that the spinal processes are lighter and then they get darker as you move up. You should also be able to see the sternum. Can you all see my arrow?
Yes.
Okay,
Yes.
so this is the sternum here. You can see this line here, and you can see the spinal processes get lighter as you move forward. So this is good penetration on this film. Um, on this x-ray on the left, this is underpenetrated. You cannot see any of those spinal details. You cannot see anything to differentiate between the trachea, the spine, and the heart. Versus on the right, we have overpenetration. And so you start to lose all of the detail that you would want to see in the lungs. You can see this detail here. Specifically, you can see a lot of the detail here where you can see the airways and the vasculature. So again, the first thing you want to look at when you're looking at an x-ray is to make sure that you've got a good quality film, because this is not going to tell you anything. The next thing that is important, and a lot of these are important for the technologists when they're shooting the films, is rotation. The patient must be flat against the cassette. If they're rotated, it can give you all sorts of abnormal findings that could be concerning for some other type of disease process. The best way to determine this is to look at the clavicular heads. You want to make sure that they are nice and even, equal distance from the spinous processes. This x-ray, this patient is rotated, and you can see one clavicular head here, the other clavicular head over here. You see this line right here, and to the unsuspecting eye, what is going on here? Is this a pneumothorax? Actually, this is a skin fold that you can see showing up in the lung. So this is not a great x-ray. It's not going to tell you anything. You can see that the heart is rotated over into the right chest cavity. So again, the objective of radiologic studies is to detect an abnormality, to describe these findings as clearly as possible, to try and differentiate what could be going on. And so in this x-ray here, you see a well-defined mass. It has clear borders. You can see exactly where it's at. This is also a mass, but it's very poorly defined. And so when you get radiology reports, this is the difference, what they're talking about when they say well-defined, nice clear borders versus not well-defined here. The next thing the radiology report or viewing the radiology image will allow you to see is the location. You can see masses in three different locations in the thoracic cavity. You may see intraparenchymal, which is here. It's within the body of the lung. Pleural, which is outside of the lung, but still within the thoracic cavity, and extrapleural, which is this location right here, outside of the pleura. Masses can also be described as pleural based versus extrapleural. This one is considered pleural based. This is the pleura, this white line here, and you can see that this fits right in with that, versus extrapleural, which is outside of the pleura here. So when you're looking at lungs, your right lung has an upper, middle, and lower lobe, and your left lung has an upper and lower lobe. Within the lungs, they will also describe the fissures, oblique and minor or horizontal fissures. These are the lines that are artificially made by where the lobes of the lung come together. So a fissure is a groove seen on x-rays that separates the lobes of the lung. The transverse fissure divides the right middle lobe from the right upper lobe. And then the oblique or major fissure divides the right lower lobe from the right upper and middle lobes, and the left lower lobe from the left upper lobe. And so here is a picture of the fissures and the lobes. Um, the right middle lobe, right upper lobe, right lower lobe. Um, this is the minor fissure. Um, Here's the lateral view of the right lung, the right upper, right middle, and right lower lobes, left upper lobe, and left lower lobe. These are the oblique fissures. Again, divide the upper part of the lung from the lower lobe, upper part, which includes the right upper and right middle, from the right lower lobe. Here is a view of the right middle lobe on a PA film and a lateral film. And so if you look at an x-ray, we looked at one earlier, which talked about making sure that you're getting a film during inspiration, because when they got the film during expiration, it looked like this area right here was abnormal. And so that corresponds with the right middle lobe. And so when a radiologist or a pulmonologist or somebody is reading the x-rays and they see an abnormality in this area, they can definitely say, this is a right middle lobe abnormality. And that also gives us a target to investigate if we were going to move forward with a bronchoscopy or something like that. Again, when we talk about the fissure is a groove that separates the lobes of the lung. And these images, you can see there's fluid in this fissure here, and you can in this oblique fissure, and you can see the fluid here in the oblique fissure as well. This is actually a heart valve replacement. When you're looking at those fissures on CT scan, you can also differentiate them, and that's what this line is right here. This is a gross anatomy picture where you can see the fissures clearly. Again, all they are grooves, and you can see them outlined here. This is just another anatomic view. What you're seeing here is you're seeing the right upper lobe, middle lobe, lower lobe, and then within or sort of in the middle of this area is all of the vasculature. You can see lymph nodes, you can see veins, you can see arteries. And when you look at a chest x-ray, that area is fairly clearly defined as well, sitting sort of above the right middle lobe. In the right upper lobe, you can see this vascular bundle. And the same on the left side. And again, talking about the lobes and knowing your anatomy helps when you're reading these chest x-rays. You can see on this one that there is an abnormality in this area. There's an abnormality in this area, and this is the right middle lobe. So this x-ray does show a right middle lobe pneumonia. X-rays are also able to help visualize some of the mediastinal structures, although sometimes a little less clear. You can see them outlined here. Again, the diaphragm is here. This is the right atrium. The left ventricle sits over here in the aortic arch. These are probably the three main heart anatomy aspects that you can visualize on a chest x-ray. The right upper lobe lung border is here. The right middle lobe we've already talked about, sits right here. Right lower lobe along the diaphragm. On the other side, the left lower lobe sits along the diaphragm. The lingula sits along the left ventricle, and the left upper lobe is along the trachea spine area here and along the aortic knob. We also look for airway abnormalities when we're looking at chest x-rays. You can see the trachea, the main airway here. And because you're looking, when you look at a chest x-ray, through the trachea, which is full of air, into the spinous processes, that's why this area seems to be a little bit more translucent. You have better visualization of the spinous processes because there is air sitting in front of them. This is the carina. And then you see branching into the left main bronchus and the right main bronchus. The carina sits just below the aortic arch. The right mainstem bronchus then divides. The right upper lobe is the first division off, and then the right lower lobe down here. And then the left main bronchus will then divide further on into the left upper lobe and lower lobe. Just a diagram of the different bronchi. A diagram of pulmonary vasculature. And this is another picture of the pulmonary vasculature and where everything sits in relation to the trachea here and the carina here at F. Here is some pulmonary vasculature as visualized on CT scan. You can see the left pulmonary artery here. You can see the right pulmonary artery in this picture. So next, I want to talk about some signs. The first one is the silhouette sign. And when you're talking about the silhouette sign, what you're seeing is loss of a normal border between the structures. When you're looking at the exam fields on a normal chest x-ray, the silhouettes of the heart borders, the ascending and descending aorta, the aortic knob, and the hemidiaphragms should be clear. Um, if you lose any of those borders, there is some type of abnormality occurring in that area. The one that I tend to go back to because it's fairly easy to see is that right heart border. So if you lose that right heart border silhouette, you're concerned about a process that's occurring in the right middle lobe. Um, if you lose the left heart border, you're concerned about a process that's happening in the lingula. If you lose the silhouette of that aortic knob, you're concerned about the left upper lobe, specifically the apical portion. And then if you lose that silhouette along the diaphragms, you would be concerned about the lower lobes, depending on which side of the diaphragm you lose that silhouette. And so here is a picture. These are the areas that we're speaking of. If you lose this clear line of the diaphragm, you're concerned about a lower lobe process. Again, if you lose this clear sign here, you're worried about a right middle lobe process. And again, we see that here. You don't see that clear right heart border. And so again, we're seeing a process that's occurring in the right middle lobe. The other sign that we frequently discuss when we're talking about chest x-rays is the air bronchogram sign. And what this is a tubular outline of an airway that is made visible because there's some type of process occurring outside of that airway. We can see this with lung consolidation, pneumonia, edema, atelectasis, some types of interstitial disease, cancer, and then sometimes we can see this on normal expiration films as well. And so what you're seeing, if this is probably the best picture on this slide, is that you can see this tube of air here. All these arrows are sort of pointing to the border, and there's some type of process happening here, but the airway is spared, and so the airway can be seen on the x-ray with this process happening outside of there. And so one of the things that we look at if we're looking at a chest x-ray specifically, for patients that might be in the ICU and we see air bronchograms, that's a good sign that this is more likely to be a pneumonia versus a solid mass. And so that helps us to sort of narrow down our differential diagnosis and decide which treatment we want to pursue for the patient. These slides also show some air bronchograms. You can see here, here, here. Over here, you can see air bronchograms along here and here. The next thing we look at when we look at radiology studies are line tubes and drains, any type of IV catheter that can be seen that would be in the chest, any type of tube such as an endotracheal tube or an NG tube, and drains such as large bore chest tubes or pigtail catheters. So this patient here has a lot of external things happening. These here are the EKG leads. You can see this is a wire that's in their ET tube, actually. You can see some of these are external tubes that are coming from their ET tube. But they do have an IJ triple lumen catheter. And that is what this line is right here. That's coming down and terminating here. So they've got an IV in their neck that's being threaded into the chest and terminating right here. This is a left IV catheter, which is over here and terminates, in the same general area. We've got ET tubes. We've got leads here, EKG leads here. This is a subclavian line, which starts over here and terminates here at the arrow. This is a PICC line, which stands for peripherally inserted central catheter. And so that is coming through the arm and coming up and into the chest. And you can see all the abnormalities on this um, this patient's image too. You sort of lose this border here. You can see this border here, but they definitely have abnormalities throughout the lungs. This is a tunneled catheter. Um, the end of it is right here. It goes up and down and terminates here. This patient has a port, um, which is actually accessed. The port looks triangular. It's right here is the head of the port, and then you can see the line from the port going across the midline. You can see this white thing right here, sort of looks like a backwards L. This is the IV that is into this port, so this port is actually accessed on this patient. This patient has an endotracheal tube. Um, these two radiolucent lines right here come down and it terminates right here. You can see just below that is the carina. So this is actually a very good placement on this ET tube. You don't want it to be any further down. So it sits right above the carina. As opposed to this patient whose ET tube comes down here and goes straight into their right main stem, essentially making this lung not active at this point. So this tube needs pulled back to about right here where it sits above the carina so that the ventilation that we're providing to the patient gets into both lungs and not just into the right lung. This patient has a tracheostomy. That's what this is right here. And it goes down and terminates right about here. The carina is right here, and you can see going into the left lung, the main stem bronchus, and going into the right lung, the right main stem bronchus, that then branches off and goes up into the right upper lobe and down into the right middle and lower. This patient has a nasogastric tube. It is difficult to see, but it does terminate here in the stomach. It's this line right here. This is a misplaced nasogastric tube. Instead of staying in the esophagus, this one went into the trachea. You can see this line right here goes into the trachea, right into the right main stem, and then right into the right lower lobe. This is why we always get chest x-rays before we start using a nasogastric tube, because if you were to put tube feed into this, it would go straight into the lung. This patient has a pigtail catheter, which is named because of its appearance. You can see this chest tube comes in here and curls around like a pig tube, like a pig's tail. That is in contrast to a large bore chest tube, which is what this tube is right here. This little break in this radiolucent line is actually a drainage hole. And then this patient also has an ET tube that terminates here. So this is a list of just some of the things that we can see on chest imaging. We can see pulmonary edema, pneumonia. We can see changes that are specific for tuberculosis. We can see pleural effusions. We can see nodules or masses. We can see enlarged lymph nodes. So there's a lot that a basic chest X-ray can tell you, and there's a lot that a CT scan can tell you on top of what a chest X-ray can tell you. One of the findings that you may see often in chest x-ray reports is atelectasis. And what atelectasis means is a collapse or incomplete expansion of the lung. It's very common. You can see it from things like tumors or even mucus plugs that block off the airways. You can see compression from something outside of the lung, such as pleural fluid. You can see it, you can see what's called dependent atelectasis on patients that may be in a hospital bed for a period of time where they're just not aerating or using that portion of the lung. And so it doesn't inflate all of the way. You can see that's why this looks a little hazy here at the bottom. There's some atelectasis over here. And you can see on the lateral view, it's showing up here. A little bit back here too. This X-ray shows left upper lobe atelectasis, and so we're going to sort of go back to that silhouette sign where you're losing this clear outline of the aortic knob and the trachea here. And so there's some atelectasis here. You can see that here that corresponds to this area right here on this smaller picture, and this area right here. By contrast, this is left lower lobe atelectasis. So again, you're going to lose this left heart border and diaphragm. Clearly here, you're not seeing that left heart border. You're not seeing that diaphragm very clearly. And then once that atelectasis resolves, you can see a nice clear diaphragmatic border. Right upper lobe atelectasis, you're going to lose the right side of this border here. You can see this is a very clear outline where this atelectasis is occurring. And sometimes what you'll see is that this fissure actually pulls upwards, and that's what you're seeing along these arrows. Right middle lobe atelectasis, you're going to lose this right heart border. You can see this wedge-shaped defect here on the lateral view. And right lower lobe atelectasis, you lose this area right here along the diaphragm and up along the right heart border. Pulmonary edema is when you have fluid in the intrinsic portions of the lung as opposed to between the lung and the pleura. With that, you tend to see an enlarged heart, and you can see here this heart border stretches further into the right lung and over here into the left lung. So this heart is enlarged. The heart should be about half of the size of the chest. And so if you measure from here to here, it should be this distance from here to here. And so this is actually bigger than that distance. So this heart is considered enlarged. You can also see increased pulmonary vasculature. And so you can see all of these vessels here and over here, which is a typical finding with pulmonary edema, which is what we typically find with congestive heart failure. Sometimes pulmonary edema can give you a bat wing pattern where it's sort of sits in the chest and it looks like a bat wing. These are two more pictures of pulmonary edema. You can see the lungs look very hazy, very gray, but you still see this diaphragm is sort of clear. You do lose some of the costophrenic angle over here. So there is some fluid sitting over here as well. But just the whole lung gives sort of this gray, hazy appearance with pulmonary edema. So again, signs that you would see in a patient with congestive heart failure include cardiomegaly. So your heart size is enlarged, and you can clearly tell in this picture, the heart is bigger than half of the chest size. So this patient does have an enlarged heart. You can see edema within the lungs and then increased vascular markings. So pneumonia can happen in a couple of different ways. You can have sort of a diffuse pneumonia that goes across multiple lobes, or you can have a lobar pneumonia that sits only in one specific lobe. This is a space-occupying lesion, but you don't lose lung volume. So it sits in there, it takes up space, but doesn't cause like shifts of the fissure or anything like that. You can have some fluid or effusion with pneumonia. The other thing to know is that based on its appearance on an X-ray can sort of help to determine what type of organisms may cause the pneumonia. Lobar pneumonia is likely to be pneumococcal versus lobular pneumonia is more likely to be staphylococcus. And interstitial pneumonia, which sort of affects all of the lobes of the lung, is more likely to be a viral or a mycoplasma pneumonia. Aspiration pneumonia follows gravity, and so you would expect those pneumonias that are related to aspiration to be in the lower lobes of the lungs. And then sort of diffuse pulmonary infections, again, can be mycoplasma, like a community-acquired pneumonia, a hospital-acquired pneumonia, nosocomial, like Pseudomonas or ventilator-associated pneumonia. And then we also see diffuse infections in our immunocompromised patients, and these are thought to be more likely to be fungal or PCP, which is now known as PJP. Again, the right middle lobe, this is a right middle lobe pneumonia. It clearly follows lobar outline. Um, there's no pneumonia in the right upper lobe. There's no pneumonia in the right lower lobe. It is clearly a lobar pneumonia sitting right here. This is a right upper lobe pneumonia. Again, it's going to follow sort of this fissure. You can see here this oblique fissure, and this pneumonia is sitting up here. Tuberculosis can present as a consolidation. It can also present as enlarged lymph nodes. It can present as pleural effusion. Tuberculosis usually affects the upper lobes, and so that would be one thing you would think of if you had an upper lobe predominant disease. Pulmonary hemorrhage is an airspace filling process. And so you can see in this patient here, they've got blood in the lower lobe here. You don't see any diaphragm, any border at all here. And you can see right here, there is blood that just sort of filled that whole airspace. Pulmonary embolism. So this is a blood clot that happens in the lungs. It happens in the pulmonary vasculature. Most of the time, you cannot see a pulmonary embolism on a chest X-ray. The purpose of getting a chest X-ray in a patient that you suspect pulmonary embolism on is to rule out other causes of shortness of breath or hypoxia, such as pleural effusion or pneumonia or something like that. That being said, there is a classic board exam question that we're asked specifically in pulmonary boards about um, X-ray changes with pulmonary embolism. And what you can see is something called a Hampton's hump. And this is a picture of a Hampton's hump. And it's a rounded opacity. And basically, why that happens is because of lack of blood flow to that area of the lung. You can start to see a lung infarct develop, and that's what this image shows. But for most acute pulmonary embolism, you will not see any changes on the chest X-ray. You do see pulmonary embolism on the CT scan. And so what you're looking for is, again, a blood clot that sits in the pulmonary vasculature. In order to identify this, you need to give the patient IV contrast. And so that IV contrast goes into the pulmonary vasculature. And what you're looking for is an area where that contrast does not penetrate. And so you can see in both of these pictures shows a pulmonary embolism. This one is a little bit more, a little easier to see. You can see the contrast going over here, and you can see some contrast here, but you see this large pulmonary embolism here and here. In this one up above, there's a pulmonary embolism right here. You can see a little bit of contrast here at the top, but most of this blood vessel is full of clot. You can see pleural effusions or fluid on chest X-rays. Most commonly, we see this secondary to congestive heart failure or infection or trauma. And what you see is blunting of your costophrenic angle. And so these costophrenic angles is where the diaphragm and where the lung sort of extends down along the diaphragm. It should be nice and sharp, but here you can see that this is sort of blunted. You don't see a nice sharp angle here or here, and there's fluid located down here. Same thing here, you can see some fluid sort of sitting in this area. This is a collection of fluid in the lungs. This is a collection, this is actually an abscess. You can see that this is sort of walled off, and then there's some necrosis that's happened here in the center. The other thing you want to look for on a chest X-ray is a pneumothorax. A pneumothorax happens when there is air inside the thoracic cavity but outside of the lung. It looks like air without lung markings. And so again, that's when your penetration of your images becomes important because you need to be able to see those lung markings so that you can see absence of lung markings. And so this air is actually located outside of the pleura, and you can see this thin line right here is a pneumothorax. Excuse me. This is fairly easy to see in an upright film. Sorry. Um, as the air will rise, more difficult to see if a patient is lying flat on their back. This film shows a tension pneumothorax, and you can see there is absolutely no lung markings in this area. You see the ribs, but no lung behind the ribs. You can see lung here and over here. And you can see that because there is so much pressure in this area, it's actually shifted all of these structures to the left. And this is a medical emergency. And these are patients that need treated immediately because it can cause all sorts of issues up to and including death. This x-ray shows a pneumothorax along the um, right lower lobe. The other thing that you can see in addition to seeing this air is something called the deep sulcus sign. And that's what you can see here is that this air actually extends further down below, also indicative of a pneumothorax. Um, a hydropneumothorax is when you have water and air in the lung space where it's not supposed to be. And you can see from these images, what you're seeing is that this air and this water sort of layer out. This is an upright film. You can see the fluid. There's a clear line within the pleural cavity of where this fluid lies. Above it is air. And then you can see lung over here. When you turn this patient sideways, you can see a clear line of fluid here. And when you lay this patient on their side, again, this sort of layers out, and you can see this fluid here um, below the lungs. We see that with blood. We can see hemopneumothorax when blood would do this, or we can see with pleural fluid, incorrect placement of an IV. We can see this happen as well.
Dr. Cihla,
Pulmonary fib, yes.
would do you have an appropriate place where we can go ahead and stop?
Yeah, I think so. Yeah.
Okay. I'm sorry about that. I know,
No, that's my fault. Like I said, I apologize for, actually, we didn't do too bad. We're on, slide 80 of 95. So, so
oh
not
yeah,
too
not
bad.
bad.
Um, let me see. Yeah, there's a lot more detailed information coming up. So this is probably a good place to stop. But I apologize. I'm happy to answer any questions if anybody has anything based on what we've talked about already today.
Do we have anyone that has any questions for anything that was covered?